Good morning, everyone. Warm welcome to Online Anaesthesia Postgraduate Teaching Program on Zoom platform, sponsored by Acrola and hosted by A1 Logics, and simultaneously aired by Anaesthesia TV. Today we are hosting the Critical Care Series third week. Today's topic is Basic Modes and Basic Settings of Ventilator by Dr. T.R. Chandrashekar. He is the Professor and Head Department of Critical Care Medicine, Institute of Gastroenterology Sciences and Organ Transplant from Bangalore, Karnataka. He has written a textbook on mechanical ventilation, clinical application, second edition in the year 2014, published by CBS Publishers. He has also consented to deliver 2 more topics on mechanical ventilation in the coming weeks. Thank you, sir. Over to you, sir.
Thank you, sir. Thank you. Is it visible, sir? My screen is visible. Good morning to all my colleagues and my postgraduate students. Last week we did discuss, I started off teaching you how to ventilate safely so that you understand what we are going to talk in the next session. So I just wanted to create an interest so that it is something that you can take back to your operating room. So mechanical ventilation, whether it is in an operating room, whether it is in a CT room, whether it is in an endoscopy room or in a critical care, the basic understanding of physiology for clinical reasoning doesn't change. And the science is applied across the spectrum of patients we see. We may always presume that our patients have a normal lung, but as we understand as anesthesiologists, the process of anesthesia is so dynamic and so many complications can occur, and a normal lung can become a sick lung, or we do tend to have sometimes very sick lungs also coming in for emergency surgeries like polytrauma, aspirations, then any abdominal perforations. So these kind of patients also we see. So the principles applied in critical care, or it's in a remote locations or in operating theaters, would be same. So once you understand the principles of mechanical ventilation, the application would be similar in all the. So this is the equation of motion for mechanical ventilation. As I've said, the lung doesn't expand on itself, so it requires a pump. So normally the respiratory pump, which is mostly by diaphragm, creates a negative pressure, and you can think that air is being sucked into the alveoli. So the patient's effort leads to a flow going through the tubes where there is no place for the volume to be collected there. So it is flow into resistance for the airways, and then once that's called the resistive load, and once the alveoli, which are the sacs where the volume collects, it is volume divided by compliance or elastance. The inverse of compliance is elastance. That's the elastic load. For simple understanding, I would always urge the students not to confuse between compliance, elastance. See, you have to think like this. Whenever you put a volume, your pressure goes up. You have to think that your alveoli is diseased or stiffer. That is what is called as compliance. The pressure change for a volume change for a set pressure is the compliance. So whenever the pressure goes up for a set volume that is being delivered, say when we start with ventilation, we are giving a 6 ml or 7 ml tidal volume, your plateau pressure was 14. And with pneumoperitoneum, it goes up to 20. So now you have to make a decision whether the alveoli is a problem or the chest wall. As we know, it is suddenly happened because of a post volume being put into the abdomen. We presume or we assume that it is mostly because of the chest wall contributing so that the pressures have gone up. Sometimes there may be both. There may be both a position change, also a lung pathology. It is very difficult to distinguish, but most of the times, once you see a rise in the plateau pressure, if you see the difference between the PIP and plateau, if it is more, it is the respiratory, it's a airway component. If it is not, it has to be between the alveoli and the chest wall. And chest wall is mostly by clinical deduction. We presume that it is the contribution from the chest wall. Whenever it is presumed to be from the chest wall, you can apply more pressure. You can apply more PEEP, about 10, 12 in a obese lady, or with a posture change, you can go up and you can do repeated recruitment maneuvers. So when it is an alveolar issue, then you have to be careful with the application of PEEP and recruitment maneuvers. This is what we learned last week. So this is the equation of motion. Now, when the patient is not able to breathe, see, otherwise we won't put a ventilator, isn't it? Whenever we feel that patient is not capable to deliver a volume into our alveoli, we give a ventilator assistance. But the issue most of the anesthetists have to think and understand is most of our patients are paralyzed. So the patient effort is removed out of the equation in a operating theater. When we anesthetize, we give a neuromuscular blocker, the patient is totally paralyzed. It's a complete 100% ventilatory assistance leads to overcoming the resistance and producing a volume in the alveoli. This is what, but while you extubate during induction, emergence, there will be a component of both. So it is better to learn, and in a present day practice, lot of pressure support ventilation, especially with the LMA, is being applied. So this is what is coming into operating theater also. So understanding, and most of the medical colleges, the critical care is managed by anesthesiologists. So it is better to learn all the modes and the intricacies or the physiology involved so that you can go and clinically deduct what is best to your patient. So how most of the younger colleagues always ask me, how do you decide about a mode? So you have to make a decision how much your patient is capable of taking a load. For example, in anesthesia with neuromuscular blockade, it is 0. So the total assistance has to be from the ventilator. When you shift him to a critical care after a few hours, once the neuromuscular blockade goes, then probably you may have to introduce a pressure control, going on to a pressure support ventilation, then TPs and extubation. So the judgment is always how you analyze what is the capacity of my patient to support, and the rest goes to the ventilator. So different modes can be applied, and it is not rocket science. It is very, very easy. In the next 1 hour, I will see to it that you understand what are modes and what is the application, how to introduce modes to the patient to the best of your capabilities, and always looking at the 3 things have to be considered when a mode is considered: safety, comfort, and weaning. Safety, comfort, and weaning. So there are different modes. Some modes only for safety. See, when you are ventilating in anesthesia, our only goal is a controlled ventilation, is safety. There is no question of comfort because there is no interaction, and weaning doesn't happen unless we reverse. So that is a different ball game. After 10-15 days, a OP poison is being weaned, then the lung is better now. The lung after aspiration has become, or a pneumonia patient or a COVID patient, after 10 days, his lung has recovered well. So then there is no question of safety. Only we consider comfort and weaning. So the modes change. So that is what you have to understand. So this is what we don't have in an anesthesia setting. So as I have said, with neuromuscular and controlled ventilation, most of the times we use volume controlled ventilation. In a Las Vegas study also, I have shown you 70% of the patients were ventilated with controlled ventilation, and about 20 to 30% with pressure controlled or pressure limited ventilation. As I said, some application during induction, extubation, and LMA in some cases of, for example, ERCPs, or some hip surgeries also have been done with a LMA with a pressure support mode. So pressure support also, the application is coming into the operating room. So what are the advantages? If you ask me, volume control, it is always easy to estimate P plat. So it is very important. We know what the volume, what is the reaction with the alveoli, what is the pressure it is producing. We know the boundaries of lung protective ventilation. We know that the P plat has to be around 16, 17, driving pressure has to be around 12, 13. So we know the boundaries. So P plat estimation is very, very important. So volume is assured irrespective of what the pressure goes up. So you have to monitor the pressure. See, in volume ventilation, volume is assured, pressure is the parameter which changes according to the lung condition. So that is what you have to monitor. Whereas if you go to pressure control, it's a decelerating flow. It is considered to be more physiological. Recruitment maneuvers, a single shot recruitment maneuver is easy to do on a pressure control. pressure and safety are assured, but hypoventilation occurs because you set the pressure. I will explain it in the next 1 or 2 slides. That is very easy to understand. What is, see, when we speak of volume or pressure, the people, the younger postgraduates get to confuse what it is, what am I setting? If there is pressure, is there no volume? Or if there is a volume, is there no pressure? So that understanding is the first step in understanding the modes. In the next 2-3 slides, I'll make it very, very clear what it means for you when a volume is set or a pressure is set. And this is what you have to always do. And how does the P-plat come? P-plat is always with a square wave, constant flow in a volume control. And postgraduates can type, how do you get a P-plat on a ventilator by pressing which button for how many seconds? Just to have a revision of what we learned. And that is the most important thing, because whatever you set is the intensive property. The capacity, it goes and interacts with the capacitance of your lung, meaning how much of lung is there, how many million alveoli are there to accept the tidal volume. Once that interacts, you get a pressure, and we know the boundaries beyond which it cannot go, because it causes post-pulmonary complications. In a sicker lung, it increases mortality also. So P-plat is the first thing that you have to learn whenever you apply. So some physiology, because I've always thought that understanding physiology makes it easy for clinical reasoning. Whenever we get into some complex situations, if you don't understand physiology, then you won't be able to solve the problem. So understanding physiology is the it's what makes a good doctor, good clinician at the bedside. So then you will have a clinical reasoning. So understanding physiology is very, very important. See, this is what is the way a neuroventilatory coupling occurs from the respiratory center output to blood being delivered, the volume being delivered, diaphragm going down and air being sucked in. What you have to understand is most of our ventilators use a pressure drop once the diaphragm contracts. So once the respiratory output center gives output, it has to come, there has to be a diaphragmatic contraction, then only the air gets in. Then only the ventilator will know that the patient is trying to breathe. So the way we ventilate or the modes we have, most of the common basic modes, there is inertly a small delay from the respiratory output to the ventilatory input. So that is what you have to consider. But it is very, very small. In most of the cases, it may not cause asynchrony, but in sick patients who are having a lot of fever, tachycardia, tachypnea, these are the patients who may have dysynchrony because or asynchrony because of this. There is an inert issue here. From the output to diaphragm contracting, air being sucked in, ventilator being told that, okay, the patient requires a volume and the inspiratory flow starting, there is an inert problem. Are we better? Are there any modes which have gone up in the cycle and started getting information much earlier? Yes, there is one mode called NAVA, neurally adjusted ventilatory assist, where we put a esophageal probe which picks up the electrical activity of the diaphragm and the tidal volume is delivered with the activity. We attach a pressure support to the amount of electrical activity we tend to get from the diaphragm, and then the ventilation starts. It is, as of today, it is considered the most physiological mode because the electrical activity of the diaphragm is proportional to the respiratory center output. So when you put a NAVA, it is like almost like a respiratory center controlling your breathing. So if you have access to NAVA, probably in any spontaneously breathing patient should be on NAVA. There are some other modes which consider resistance and compliance much better than where we see the airway sucking in being communicated to the ventilator. Those are proportional assist ventilation and adaptive support ventilation. If it is available, those are better physiological modes. And the rest of the modes are all like, these are all the PRVC, volume support. These are all like the minute ventilation assurance modes. They are not very physiological. I would say they are better than you standing there and setting every 5 minutes. They are more superior in setting, not more superior physiologically in breath delivery. These are the only 3 modes which are very, very physiological. And when you talk of basic modes, what you have to understand is once you set a parameter like a tidal volume of 400, unless you change 400 ml keeps on going. Whereas whether it is in a volume support or a PRVC or a NAVA or a proportional assist ventilation, there is some communication. It analyzes what is going in, what are the pressures, what is happening. It tries to alter breath to breath. But in basic modes, we don't have this option. That's why we did a lot of research and we have come up with newer modes. But what an anesthesiologist should analyze is all these modes application occurs only when the patient starts interacting, or when patient starts getting up, patient starts weaning, or when the primary pathology is being rectified. As in the operating theater, you don't have to look beyond these three modes. You don't have to move. In fact, there is no publication to the effect that the modes per se are changing or altering the pathology or morbidity or mortality in any disease process, because there are so many confounding pathologies. It is very difficult to isolate only a mode's contribution to survival or outcomes in a patient. So it is very difficult to study. But as an anesthesiologist, my submission is, because the patient is paralyzed, there is no interaction, all the workload is being done by a ventilator, you don't require to look anything beyond a volume control most of the times, pressure control, and as the applications of pressure support comes, looking at pressure support. In fact, all the three modes can be applied to all the patients, however sick he is, if you know the physiology and the science behind modes of ventilation. Another thing I want the postgraduates to understand is, whenever we talk of a ventilator, we are talking of I time means ventilatory I time. Expiratory time means ventilatory expiratory time. We don't have a means to analyze what is the neural inspiratory time and neural expiratory time. So when we set and say that, okay, I've set it at 1:2, it may not be appropriate, because the neural in a COPD patient, there is a expiratory flow limitation, carbon dioxide is going up, patient is becoming tachypneic, probably requires more expiratory time. We don't have a means of looking at that time. So whenever a patient tries to fight or is not syncing to your ventilator, you should think, what I have said is not what the brain wants. So then you have to work around it. So this is something you have to remember. What you set, you just cannot say that I have set a good inspiratory time, good expiratory time, because we don't have any means to analyze, understand, or estimate the neural inspiratory and neural expiratory time. So most of the times, patients do, about 80%, 90% of the patients are easy to ventilate. There is no difficulty. But that 10% is when it doesn't, there is no synchrony. Then you have to think something is happening. Then you have to physiologically understand what is happening, then clinically reason, and then try to set it up. There are some good modes, like if you put to NAVA, probably as the diaphragmatic contraction starts, ventilation starts. As the diaphragmatic contraction comes down to a certain extent, the expiration sets in. That is like estimating, and it works towards the neural inspiratory and neural expiratory time. But always remember, the support is again pressure support. NAVA is only picking up the electrical activity of the diaphragm, but the support is pressure support. So once all the modes, all the advanced modes are based on only two modes, pressure support and pressure control. So once you understand pressure support and pressure control, you can boldly say that I know all the modes. It is just understanding the application, how somebody has produced a target, and then he has made a with nanotechnology, artificial intelligence, a looping where the information is gathered, and according to the information, the tidal volume or the whatever, the pressures change. So that is how the advanced modes are. But the basic understanding that you should have is even your proportional assist ventilation is a pressure support based, whereas your adaptive support ventilation is pressure control and pressure support based. So all the modes are based on only these three modes. So if you ask me, there are only three modes in mechanical ventilation. The rest are all kind of a tweaking in here and there, having a target system and ventilating. See, now if I put a pressure support, I have put a pressure support of 10, and the patient is generating 400 ml. If the lung goes bad, for whatever reason, there is an aspiration or the lung has gone into pulmonary edema, then there is a sudden increase. So for the 10 pressure support, now he is going to produce 300 ml. See here, unless you increase the pressure support to 14, the tidal volume will not, just a number to make you understand this will not happen. If the compliance increases, then the patient may generate 500, 600 ml. Then you have to decrease. This is the disadvantage of these 3 modes. Whereas you look at this, there is a mode called volume support mode, which is a modification of pressure support, where we say, I want a tidal volume of 300. I will give you a range of pressure support from 10 to 20. So there is a target and there is a range of pressure support. So every 4 or 5 breaths, it will analyze the tidal volume. If the tidal volume comes down, then the pressure support keeps increasing. So if you think that volume support is a very new mode, it is not a new mode. It is a pressure support based mode, where we have told the ventilator, or the ventilator has a technology where it analyzes the tidal volume, and we have given a range of pressure support. So newer modes are not very different. It is very, very simple to understand. I'll try to make you see 1 or 2 modes so that you understand. Once you understand the basic physiology, how these 3 modes work, you can go back and analyze all the modes. So having said that, see, I have underscored 2 points here. What you have to understand is, whenever there is an inert delay in all the conventional basic modes we use. And second thing is, we don't have a means to estimate neural inspiratory and neural expiratory time. So inertly, there is some dysynchrony that can happen, but most of the patients, in the normal healthy patients, dysynchrony doesn't happen. So coming to what a ventilator does. So with so many components, what do you think a ventilator does? Remember this, ventilator does only one thing. It does only one thing. You have to remember this. It produces an inspiratory flow of gas. It doesn't do anything other than that. Whatever you set, first thing it does is it produces an inspiratory flow of gas. It goes through the airways and gets into the alveoli. The whole idea of putting somebody on a ventilator is to deliver a volume into the alveoli so that gas exchange occurs, oxygen goes to the mitochondria, and the patient survives. Isn't it? But the ventilator only produces an inspiratory flow of gas. And you can set it in only 2 ways. You can set it. You can tell the ventilator one of the 2. You can tell the ventilator, you deliver a flow of gas till the tidal volume that what I have set is achieved. That is called volume modes. Or I can tell the ventilator, you give a flow till the pressure of what I have set. Say, for example, in this case, 20 centimeters. So the ventilator will produce a flow, and once the pressure of 20 centimeters is sensed on the circuit, the flow will stop. So once we talk saying that it is a volume limited or a pressure limited ventilation, don't think there is no flow. There is flow, but we have said to the ventilator, you have a target, that is the volume target, here the pressure target. Any doubts on this? So when we say any volume limited, volume assist volume, or volume controlled ventilation, your understanding should be that there is a flow of gas from the ventilator till a set tidal volume is delivered. Even if the lung is sick, 400 ml will go. What will change? If the alveoli is normal, see, say we were anesthetized a patient, we were giving 400 ml, there was a positional change. We have put him on a reverse Trendelenburg position. Now, will 400 ml go? Definitely 400 ml will go. If the plateau pressure was around 11 when he was supine, now the plateau pressure may go up to 15, 20. So irrespective of the pressure change, volume will be delivered. Consider the same example in pressure ventilation now. 20 centimeters. He was getting 400 ml. Now I turn him to reverse Trendelenburg. Now he doesn't have a means to increase the volume, because once the 20 centimeters is achieved, the flow will stop. Because the diaphragm, everything is abdominal contents are compressing your lung. The pressure is achieved with a tidal volume of 200 ml. So here hypoventilation is possible. That is what you have to remember. See, these are only these 2 modes. If they're linked to a target system, all your advanced modes come. So don't confuse. Advanced modes are nothing but a pressure control or a pressure support linked to some target scheme, and then advanced modes are produced. We don't use volume control because when safety is a parameter that we require, we always put the patient on volume control and put him on a neuromuscular blockade. And in anesthesia, this is the only primary concern, because once the patient wakes up, probably we will extubate the patient, or if the patient is a long duration like a liver transplant or a CABG, sometimes you may have to shift them to pressure control or a pressure support and then shift him to a ICU, ventilate for a few hours or a day and extubate. Then the concept of comfort and liberation come. Whenever we come to comfort and liberation, we always go with pressure control and pressure support. And you don't, when the patient doesn't have an interactant, you don't require to produce any advanced modes. There is nothing to do there. So when safety is there, volume control. When you want the patient interaction where safety, where comfort and liberation becomes a primary goal, then we have some target schemes and advanced modes are there. So what I want the postgraduates to understand is, because there are nearly 175 to 200 modes, don't think each mode is different. All modes have only two ways the modes are being delivered. Either it will be pressure control or pressure support, or maybe both in a single breath, in a single cycle in a minute. But it is always pressure support or pressure. Once you understand this, you just have to sit and analyze what is happening. Then you will know how the mode works. See, this is what happens. Volume or pressure. Always think, what is the breath delivery, volume or pressure? Then what is the breath type that I'm giving? Volume, pressure control or pressure support? Then what is the target? What is the targeting scene? Then that becomes the advanced mode. See, these two, without these two, these two are not there. See, once you understand these two, all the modes are based on only this. That is what I want to underscore. Don't get bogged down or don't feel that there are 180 modes, 200 modes. How can I learn? It is all simple deduction and understanding what is the adaptive mechanism, what is the artificial intelligence that is being used, why it is being used. You rationalize and you will understand it better. See, basic modes targeting scheme becomes advanced modes. See, this is volume support. See what is happening here. The patient, I have given a range of from 8 to 17 or 20. See, I have given a range from 5 to 25. I have given a range from 5 to 25. I have said that I want a tidal volume of 450. So it will give 8 and see, it gives 12. Then wherever it achieves, then it stops. Once the lung starts improving, then the tidal volume goes beyond 400, it keeps on decreasing. Or if the patient is doing well at 12, suddenly has some lung pathology, it will start increasing. But at 25, if it is not able to achieve the tidal volume, what we have said, probably it will give an alarm and say. But what you have to understand is, it is all based on pressure support. This is a pressure support breath. That is what you have to understand. The target, see, target is 200 ml, 400 ml. See, it is 200 ml at 5, then it is not achieved or not achieved. See, at 12 it is achieving. It will hold it here only. And if the lung has some pathology, then the pressure support keeps going up till 25. That's the limit you have set. So when you talk of a newer mode, don't think it's a new, it is pressure support based. You have to see whether it is volume or pressure. Next is which support, pressure support, pressure control, what is the breath type. Then you have to see what is the target that is being set, what is happening. Then you understand, then you know how to use it. So coming back to the anatomy of the ventilator, ventilator will have so many controls, valves, sensors, pressure gauges and things like that, expiratory valve, inspiratory valve. For you and me, the ventilator just produces an inspiratory flow of gas. See, it just produces an inspiratory flow of gas, inspiration, inspiratory flow of gas, the lung expands, diaphragm contracts. During expiration, ventilator doesn't do anything. The elastic recoil of whenever elastic structure is stretched, it tries to come back to the original shape. That force only does the expiration. So conventional ventilator does not support expiration, meaning there is no sucking of air. Doesn't mean that you can't alter the expiration. You can alter the expiratory time, you can put a PEEP, what I mean to say that like air being pushed in, there is no air being sucked in in a conventional ventilator. The elastic recoil tendency to attain the normal position brings the air out, but it is not a passive process. It is an energy requiring process that also has to be understood. So what does a ventilator generate? Ventilator generates a inspiratory flow of gas. That is the only thing it does. And flow occurs only when there is a pressure difference. I have told you. In a normal breathing, diaphragm contracts. Here the airway pressure by the ventilator at the mouth is being increased so that there is a pressure difference between your alveoli and this thing. There is a flow. So pressure difference has to be attained. Either it is by negative pressure or positive pressure. Because it is a positive pressure, we call it as positive pressure ventilation. Flow for a given time is a tidal volume delivered. See, this is something you have to understand. I find it very, very difficult to explain this. Most of the postgraduates don't understand what I mean to say that when you talk of a flow, see, I've said ventilator generates only inspiratory flow of gas. When you talk flow in the time, in the flow, inspiratory flow in the context of time, then it becomes tidal volume delivered. See, I'll explain it to you in the next step. See, you see here, there is a bucket, and for 1 minute, if you say that the flow is constant here. See, flow I have fixed, it is 250 ml. If I give it for 2 minutes, what happens? How much water will I get, more or less? The flow is same. I'm waiting there for 1 minute, 250 ml will fill. If I wait for 1 more minute, will it be 250 ml or more? Obviously, it will be more, isn't it? So flow for a given time is the volume delivered. Is it understood? If you think this is the flow the ventilator is producing, this is your alveoli. If you increase the time, or if you look at, or if you conceptualize, or if you fragment inspiratory flow in the context of time, it becomes a volume. So flow and volume are same. Flow in the context of time becomes volume delivered. So when you set a peak flow and a tidal volume, you should not confuse. Both are same. Tidal volume and peak flow are same. Because when we talked of tidal volume, we are talking of a flow for a time. Then it becomes volume. Now see, I have kept the same thing, but I have increased the flow. So delivering tidal volume, a set tidal volume can be done by altering the flow or altering the time, because this becomes important concept in inverse ratio ventilation and in COPD ventilation. See, you can increase the peak flows, deliver the tidal volume faster, and give more time for expiration. So two concepts I've told here. One is constant flow. I can increase the time, increase the tidal volume, or same time, increase the flow and increase the tidal volume. This is something you have to understand mechanical ventilation. I don't think it is very difficult. The slides are with Dr. Johnson. I've told him to give it to all delegates. You can sit and revise. If you have any issues in the next class, you can put it in the chat box, or you can WhatsApp me or send it through the mail. I'll try to clarify. See, alveoli is a cul-de-sac. I've already told there is only one way the air gets in, air gets out. So when you put a volume into the closed space, what increases? Pressure increases. And these pressures, what we are looking are two pressures, plateau pressure and driving pressure. See, why I'm always talking of physiology here only is because, however, whatever the mode you said, if you have a tidal volume of 6 to 7 ml, a PEEP of 5, recruitment maneuver only when PEEP doesn't work, and if you are within the lung protective ventilation boundaries of a plateau pressure of less than 17 and a driving pressure less than 13, you will not harm your lung. That is the idea. Whatever the modes don't help. The framework of lung protective ventilation is same for all the modes. That is what is the thing that I want to underscore. And air always chooses the path of least resistance. So whenever lung is, some alveoli are collapsed because of a supine position, reverse Trendelenburg, or whatever, the tidal volume delivered has to be reduced. And we have already understood that in a anesthesia patient, the tidal volumes we use is around 6.5 to 7.5 ml per kg. You don't require to use anything more. So they are all interdependent. These are something, the purpose of mechanical ventilation is to put a volume into the lung. For volume to get into the lung, flow is required, and flow occurs only when there is a pressure gradient. And there are two ways of creating pressure gradient. I've told positive or negative pressure, and volume in a cul-de-sac pressure changes, and air always flow for a certain time is volume delivered, and air always chooses the path of least resistance. These are some of the physiological aspects that is there. You can't change this. So once you understand this, then the clinical deduction starts. And they are all interdependent. As I've said, when flow increases and the time is not increasing, volume delivered will increase. When flow is kept constant, time is increased, then also tidal volume delivered will be increased. So flow and time is volume. That is what you have to understand. I will tell you how to manipulate those two in a COPD patient so that you will understand better. So now, this is all the physiology that you have to understand. If you find it difficult to understand at a single go, kindly revise. If you have any issues, you can get back to us. We'll try to make you understand. See, intuitively, a ventilatory mode refers to a predefined pattern interaction between patient and ventilator, isn't it? As I have said, in anesthesia, there is no interaction at all. All 100% is being delivered by a ventilator. And most of our patients have a normal lung. So ventilation per se doesn't cause much of a difficulty to us. But in the last session, I've taught you that the incidence is about 40 to 50%, especially in a long duration surgeries of the post-pulmonary complications. So lung protective ventilation has to be implemented in operating theater also. The first question always when you try to understand a mode is whether it is a volume mode or a pressure mode. I have told you what is a volume mode. In the next slide, I will make you understand what exactly happens, how you have to understand what is volume mode and pressure mode. Then second question is, what is the control variables within the breath? There are three questions. Who starts a breath? Who limits a breath? And what changes the breath from the inspiration to expiration? That is the third question, second question you have to answer. And the third question is breath sequencing. Whether this breath in a minute, does it have only mandatory breaths or a limited breaths? Or do you have mandatory breath, assisted breath, supported breaths, or a combination of them is what you have to look at. Like in SIMV, if you put a patient on a pressure control SIMV, he will have a mandatory breath, he will have a supported breath. So then you will know, oh, this mode has capacity to produce a mandatory breath, a spontaneous breath, or a supported breath, pressure supported breath. That is the third question you have to answer. If you answer these three questions, you will understand the basic modes. Then get into the targeting system. Then once you understand the targeting system, all the advanced modes are answered. All the advanced modes are based on pressure control and pressure support. This is what you have to understand. See, this is what we have seen. No, I have said that either a ventilator only produces an inspiratory flow of gas, and you have only two options. Either you can set it for a prefixed tidal volume or a prefixed pressure. So in a prefixed tidal volume, it will always be a square wave. It divides the time into smaller segments and the flow is fixed. That's why you get a square wave. And we don't breathe like that. So in a patient who is trying to breathe, if you keep him on a volume control or assist volume control with a square wave, there will be dyssynchrony. The pressurization, if he wants to draw air more, see when we breathe, normally during the first few seconds of inspiration, we take a lot of air, then slowly decrease. This is the pattern, decelerating. So pressure modes are more physiological because they give, whatever amount of flow he requires till the pressure is achieved. So it is more physiological. It doesn't feel air hunger. So this decelerating flow is more physiological, whereas a square with the fixed flow is not very physiological. This is something you have to understand. In the next class, when I talk of graphics, whenever you see a square wave, your deduction is it's a volume controlled ventilation. If you see a decelerating wave, it is always a pressure wave. So standing wherever in the end of the OT also, if you look at the screen, In the monitor, if you see a square wave, it is volume ventilation. If it is a decelerating wave, it is a pressure ventilation. You need not go near the ventilator. I can make out what it is. See, this is what I said. It's a fixed flow. Patient may not be comfortable. The peak, flat, and deep driving pressures change depending upon the stiffness. See, the pressures what we achieve for a set 400 ml between the two alveoli will be different. This will be more, this will be less. But here, what happens is your P flat is fixed. I have fixed the pressure. I have fixed at 30 centimeters or 20 centimeters. Once I fix, if the alveoli becomes like this, I tend to have lesser volume. And there is no volume button on a pressure modes. You have to alter the pressure. You have to give the ventilator more pressure so that the set or the tidal volume that you have in mind is achieved for that patient. So when you try to go and find a volume mode in a pressure, it won't be there. You have to understand volume is delivered till the pressure is achieved. The next slide, look at here. In a volume controlled ventilation, I have put the patient to a volume, tidal volume of 500 and my P flat is 20 centimeters. Now, irrespective of how the alveoli is there, the volume will increase. The volume is delivered. So what happens to the pressure? Pressure will increase or decrease? Can somebody type? Pressure will increase or decrease? Some postgraduate, see, in volume, I have told the ventilator, deliver 500 ml. Will increase, yes, obviously, isn't it? Because it's a prefixed one. So now what happens? See, the P flat became 30. But that is what you have to monitor. You have to understand in a volume controlled ventilation, irrespective of what the pressure change occurs, volume is delivered. So you should monitor P flat and driving pressure. Look at here. See, I have told the ventilator, you give a flow till you achieve a pressure of 25 centimeters. It was giving 500 ml. So what will be the tidal volume delivered here? Can somebody type? Obviously, it decreases, isn't it? Because in a cul-de-sac, if the alveoli is stiffer, it produces more pressure. So the pressure is achieved for a lesser volume. So 300 ml. So now I want 500 ml. What should I increase? But I want 500 ml. What should I increase? Is there a volume button here in a pressure controlled or a pressure support ventilation? Can somebody type, what should I increase now? That is the pressure limit. So I think most of you have understood very clearly that in a pressure mode, you have to tell the ventilator, I'll give you more range. I will increase it to 30 centimeters or 35 centimeters. Then only the volume will be achieved. Whether it is within the boundary of lung protective ventilation, let us think afterwards. To understand pressure modes, this is what you have to understand. I hope, I'm sure most of you have got it right. So, see, I have to increase to 30 centimeters to get 400 ml. That is what you have to understand. So next question is, first we have achieved. First question we have answered. What is, whenever you see, you have to think whether it's a volume limited or pressure limited. Once you answer that question, next you have to come to the next question. Who triggers the inspiration? Who limits the inspiration? Who cycles the inspiration from expiration to? See, these are the three phases you have to understand. Who initiates? See, there are only two components who can start the breath, either the patient or there are only two people who can, two components, isn't it? Through the ventilator, a clinician can initiate a breath or a patient can initiate a breath. So trigger can be done with only two components, two people, two entities. And it is when it is a ventilator, it is always time. Remember this, ventilator doesn't know anything other than time. When it is initiating, it's always time. If you say 10 breaths, every 6 seconds it starts a breath. But how a patient initiates a breath, we'll see. Limiting is always by the ventilator. Limiting is always by the ventilator. Limit is always by the ventilator. In tidal or in volume control, it is volume, or in pressure control, it is pressure. This is always limited by the ventilator. See, the limiting has started here only, but the cycling is occurring here. Don't confuse limiting and cycling. Limiting starts here only, but the cycling occurs after the lapse of time. After the lapse of high time, the cycling occurs. So who determines who can cycle? Again, two components, either the ventilator or the patient. And when it is ventilator, it is mostly with the elapse of time. Whenever ventilator is involved, it initiates by the elapse of time, or it cycles from inspiration to expiration with the elapse of time only. Even though we say volume limited, pressure limited, but once the inspiratory time is done, it cycles from inspiration to expiration. There is only one mode where the patient can cycle on its own, and that mode is pressure support mode. And it is a flow cycling. I'll teach you how it is. So why pressure support is more physiological? Because there are three phases, 1, 2, 3, and the third phase is here, pressurizing phase. Whereas in a volume control, the pressurizing is constant and it is not very synchronous to the patient. Whereas in a pressure modes, the flow occurs as the patient draws more and more, it gives more and more. So the pressurization part is more physiological in pressure modes. So whenever somebody starts breathing, don't keep in volume modes. Always go to pressure control or pressure support. So there are four ways of interaction, but this is only very limited scope. So I've left it out not to complicate things. So who initiates, who limits? Limit is always by the ventilator. Who initiates, who cycles next becomes the question. And there is all the modes. There is only one mode where the patient can initiate and cycle, that is the pressure support ventilator. The rest is either patient will initiate, but it is cycled by the ventilator. As I said, flow delivery is something you have to, pressurization is something you have to consider. Now, we have understood that ventilator will start a breath only by elapse of time. So how does the ventilator or the patient tell the ventilator that I want a breath? How does it tell? How does it trigger? So that is the next question. So time, it's always ventilator. If ventilator is, it's always time based. But if it is a patient, there are two types of triggers. One is pressure trigger and flow trigger. And this doesn't come into application unless the patient breathes. In your patients whom you are paralyzed, there is no component of the patient. So it doesn't come. But when you are shifting the patient to the ICU on a pressure support or a pressure control, then the pressure trigger and flow trigger comes into question. The ventilator company guys will come and say that flow trigger is better than pressure trigger. There is no evidence to that effect. Both work same because of the technology and improvement. Both the triggers work same. And flow trigger ventilators are more expensive. Remember that. You don't require to buy. So if you set a trigger of minus 0.5 centimeters, once minus 0.5 centimeters of pressure, negative pressure is created in the circuit, the ventilator doesn't start a inspiratory flow. So obviously, if you keep a trigger of minus 5 centimeters, the patient has to trigger minus 5 centimeters. I have seen this patients being put on minus 5 centimeters. You know what? For a normal breathing, the amount of negative pressure we create is around 2 to 4 centimeters. If you keep it on a ventilator minus 5 centimeters, if he is capable of triggering minus 5 centimeters, probably should not be on a ventilator, isn't it? Because for a normal tidal volume generation, we don't require to trigger that much. Trigger always has to be between 1 to 2. If it is a flow trigger, 1 liter to 2 liters. If it is a pressure trigger, 1 centimeter of water to 2 centimeter of water. If you keep a very high trigger, lot of breaths will not be triggered. There will be a lot of missed breaths, and patient may be working more on a ventilator than off a ventilator. Just because you put a patient on a ventilator, don't presume that the work of breathing is being completely taken by the ventilator. If you set the trigger improperly, then the amount of work done by the patient is so high that he may be doing more work. If he is not on a ventilator, probably he would be doing less work. Meaning, always look at the trigger when the patient starts breathing. It has to be between 1 to 2. Remember that. And the logic behind that is to generate a normal tidal volume, you don't require to generate more than 3 to 5 centimeters of water. So trigger has to be very small, 0.5 to around 2 centimeters would be ideal. And another thing, what I want you to understand is improper trigger setting is the reason for almost 50 to 60% of asynchrony in the ICU. It's a very simple thing to do, isn't it? So that is why I'm stressing. So this is how the trigger works. See, if I increase the trigger to 1 centimeter, then the patient has to generate so much. If I make it 5 centimeters, he has to generate a negative pressure till here, which is not possible and isn't required to. If somebody is capable of generating 5 centimeters, probably he should not be on a ventilator. So how does the flow trigger occurs? There is a flow and some flow goes in when the patient starts breathing, and the ventilator analyzes, it knows that some flow, I have lost some flow, patient has drawn some flow. So then it initiates a breath. This is how the flow triggering occurs. All the values have been put. This is the science behind it. You can go through that. See, improper trigger setting is responsible for more than 50% of asynchrony. Pressure trigger is 1 to 2, flow trigger is 1 to 2. That is what you have to remember. Then cycling, limiting, I have already said, it is always by the ventilator. Cycling is by time cycling, volume cycling. Volume again is by the elapse of time only, inspiratory time. And then patient is flow cycling. There is only one mode where patient can cycle, and that is the pressure support mode. See, this is the limiting, this is the cycling. It's a decelerating flow. Whenever you see a decelerating flow, you should know that it's a pressure limiting or pressure based breath. See, here it's a square mode. See, again, this is a decelerating. The difference between the two is this is a pressure controlled breath. It has to touch the timeline and then it cycles. Whereas the cycling in a pressure support mode happens much above. How does it happen? Let us learn this in the next 2 slides. It's important. This is time cycling. This is volume. This is also elapse of time. This is also elapse of time. These are ventilator control. Whenever ventilator control is there, it is time. And this is the only mode. You remember that in all ventilation, there is only one mode where a patient can initiate a breath and change from inspiration to expiration, that is pressure support. And studies have shown that almost 80% of the time a patient spends on a ventilator in ICU is on this mode or modes based on pressure support. So learning pressure support is very, very important to be a good, to produce good outcomes in a ventilated patient. See, how does it cycle? How does the patient cycle? See, it calculates the peak expiratory flow. If the peak expiratory flow is 100 liters, by default, when the flow starts decelerating, because the pressure has been achieved, 20 centimeters pressures we gave, it started, so then the flow doesn't occur. So flow starts decelerating. When the flow comes to 25 liters, see, flow comes from 75, 50 at 25, inspiration stops and expiration begins. This is how the pressure support ventilation occurs. If I say it is flow cycling, you have to understand that the ventilation measures the peak inspiratory flow. By default, all ventilators are set at 25% of the peak inspiratory flow. This cycling occurs from inspiration to expiration. We have an option of shifting. In COPD, I will shift it to 50 because I want the inspiration to end here. And I want more time for expiration. That is how I control the IE ratio in a pressure support mode. I will show you in some other slides. You always remember flow cycling occurs like this. Peak flow 25% or 50% or 70%. You can set it, but by default it is at 25%. See, the IE ratio and respiratory rate are controlled by the patient. In a pressure support mode, we don't have the option of, but you can alter this by altering the expiratory sensitivity. It is called expiratory sensitivity because that is when the expiration starts. It is called expiratory trigger sensitivity. It is called ETS, expiratory trigger sensitivity. You have to go and see in your ventilators what it is. It is set at default 25. So if it is a controlled breath, it is triggered, limited, and cycled by the ventilator. Is it understood? If it is assist modes, it is triggered by the patient, but limited and cycled by the ventilator. If it is supported, it is triggered by the patient, limited by the ventilator, and cycled by the patient. The only mode that is pressure support. Remember this, there is only one mode, pressure support mode. And when you are breathing spontaneously, you do all that. You trigger, you limit, and you cycle, isn't it? Your brain does that for you. So there are only 3 types of breaths. One is controlled, where all the 3 phases where it is triggered, limited, and cycled by the ventilator. If it is a volume breath, it is volume limited. If it is a pressure breath, it is pressure limited, and it is time cycled. Time triggered, time cycled, limited by volume or pressure. Then if it is assisted, in control, it is not in assisted, the trigger is done by the patient. Trigger is done by either by flow trigger or pressure trigger. Here the trigger is done by time. And again, limiting and cycling is done by the ventilator. In pressure supported mode, triggering again pressure or flow, and cycling is flow cycling. This is what you have to remember. So these are the settings we do. This we learned, isn't it? Once you set here, if you want to alter the tidal volume, you have to change the pressure control limit or pressure limit. If it's pressure support, you have to change this. The rest of all the parameters are same. So I've told you how to measure the first pressure you see is PIP, then put an inspiratory mode, plateau, driving pressure, then only ventilation goes on. Otherwise, whatever mode you use, if you are not within the framework of mechanical, in the safety of lung protective ventilation, modes don't work. So this is how the volume targeted or volume limited ventilation occurs. See, I have fixed the tidal volume. I have fixed the tidal volume. So the pressure changes if the lung is problem. If the lung alveoli are problem or the chest wall, we don't know. And I have told you how to differentiate between the chest wall and the alveoli. It is mostly clinical. Otherwise, you have to put a esophageal balloon and look at the pleural pressure, which we don't do. So it is always clinically we make the judgment. See, what it happens here is in volume prefixed or volume already set, the patient alveoli or the chest wall changes or the airway changes, pressure goes up. So you have to keep a watch. Looking at the pressure, you analyze here. Whereas here, see, decelerating flow, it is touching the timeline and pressure is fixed. So when you have, see, pressure don't change here. Like the one we saw here, see, pressure changes. Whereas here, pressure doesn't change. This is prefixed, set PC level. You have to look at if the patient starts producing lesser volume, then you have to know something has happened and do the same deduction. Same deduction has to be done. Another 4 or 5 slides. I think I have another 4 minutes. Should be done. Then we'll take up some questions. See, when you want to go from a volume control to pressure control, you already know what is if he is generating 400 ml and a plateau pressure of 15, 14, then you can set the pressure limit to 15 centimeters and start the ventilation. You don't have to do much experimentation because already the intensive property is going and reacting with the capacitance of the lung and producing a pressure for that tidal volume. So when you change from volume to pressure, you use that pressure, and once you set that pressure, that tidal volume will be generated. This is how you change over from volume to pressure to set the pressure. Either it is pressure support or pressure control. That is how you set. So pressure support mode, very, very important mode. I've already told you it is the only mode where the patient initiates a breath and cycles from inspiration to expiration on its own. Initiation is either by communicating through a pressure trigger or a flow trigger. And the value that you have to set is how much? Can somebody type what is the value for pressure and volume trigger? What is the value for setting the trigger in a assist control? When a patient want the patient to communicate with the ventilator, you have to set a trigger. There are 2 types of trigger. Yeah, both one to two in between. 1 or 2 centimeters if it is pressure, 1 or 2 liters per minute is the flow trigger. Okay, good. Then you cannot set the respiratory rate. You cannot set the tidal volume. You cannot set the IE ratio. Because it's a pressure mode, tidal volume alteration has to be done with the pressure support. And the only way we can change the respiratory rate and IE ratio is by altering the rise time and expiratory trigger sensitivity. What are they? I will show you. See, this is what you see on a panel of pressure support. This is what you see on a ventilator. These are the controls. See, pressure support is 7. If I get a tidal volume of 200, I want a tidal volume of 400. What should I increase? What should I increase? There is no volume button here. My pressure support is 7. I'm getting 200 ml, but my target of 7 ml is 400 ml. What should I increase now to generate a tidal volume of 400 ml? It's a pressure-based mode. So I have given a pressure of 7 centimeters. Flow is happening at 7 centimeters. It is just producing 200 ml. So if I make it 13 or 14 centimeters probably, or 9 centimeters, pressure support. So that is something you have to understand. One. Next is we set a rate, but the rate is only as a backup. Patient can breathe even 25 times, 30 times. So he's getting 530 ml. Probably this pressure support may be more. You may have to decrease here. Now I have set a PEEP of 5. Oxygen of 40%, 50%. We understood that you don't require 50%, around less than 40% is enough. So what is wrong in this? What is wrongly set in this? What is wrongly set in this? You go one by one. Expiratory trigger sensitivity. How much is the trigger is set at 5 liters per minute. If somebody is capable of generating 5 liters of, if he is able to draw 5 liters of volume into his lung per minute, probably he should not be on a ventilator, isn't it? So what should be the trigger value? Okay. Yeah, good. Good. 1 to 2, good. So these are the two things. This is the ramp. This is the rise time. This is the expiratory trigger sensitivity. These are the two settings you can do. So how to alter them? See, rise time is increased to increase the flow, and expiratory trigger sensitivity is done to shorten the inspiratory time. It is done to shorten the inspiratory time. I'll show you how. See here. See the flow versus time scalar. See here. Okay, I have set it something. Now see here. See, I have set it at 25. Now you see the trigger. See, what is the inspiratory time here? What is the inspiratory time here? See what I have done. I have made it into 52. Expiratory trigger into 52. Meaning, as I showed you, it starts decelerating from, say, 100. For an example, I said 100 liters. Then it becomes 95, 90, then 80, 75, 50, then 25 comes. So it takes more time to reach here. So now I have made it to cut it off here only. Cut it off. By shifting the expiratory trigger sensitivity up, you are shortening the inspiratory time so that you give more time for expiration. So look at the expiratory time here. And look at the expiratory time here. It's much bigger. Expiratory, see the expiratory time here and the expiratory time here. The expiratory time is more here. So when do you want to do this? To which patients do you want to do this? And look at the volume also delivered. See here, the volume delivered. Flow into time or the pressure achieved. You can see this is the volume delivered. Flow into time is volume delivered. Flow into time is volume delivered here. So what does cycling mean? Can somebody type? Last 2 more slides. What does cycling mean to you? Yes, COPD is correct. What does cycling mean? Yeah, correct. In all patients, cycling is done by the ventilator. There is only one mode where cycling is done by patient. Which is that mode? Can somebody type? Which is the mode where patient can control the change from inspiration to expiration? And how does it happen? By what? By looking at what does the patient, the ventilator allows inspiration to go from to expiration. Not pressure support. It is flow. The flow, peak flow, 25% of the peak flow whenever achieved. It's called flow cycling. Pressure support, the cycling occurs by flow cycling, meaning when the peak flow reaches 25, which by default is set at 25, you can set it at 40, 50, whatever you want. It's called flow cycling. Type of cycling, time cycling, ventilator, only mode. Which is the only mode where patient can start and cycle the breath. It's flow cycling. In pressure support mode, what can you set? These are the things you can set. You always remember this. IE ratio and respiratory rate are controlled by who? Patient. Patient is sedated, which decreases his effort. Now you want to increase the tidal volume. How to increase the tidal volume? By increasing what? By increasing what does the tidal volume increase? Can somebody type? Yes, by pressure support level. If pressure support level is 7 and he was getting 530 ml, he was very anxious, or we wanted to do a procedure, we gave a sedation, tidal volume became 300 ml. So you have to increase the pressure. You have to increase the pressure to probably from 7 to 14 or 15 and have the same tidal volume. That is what the idea is. And just this slide to make you understand how does it work? How does rise time increase the peak flows? See here. See what have I increased? They have called it rise time. Don't confuse. If you increase the rise time, the rise where the pressure is achieved is done. So it can only, the ventilator does only one thing, isn't it? It just produces a flow. How can a flow increase? Increase the pressure by increasing the amount of flow that goes in. So though the ventilator says that it is rise time, your understanding should be by altering the rise time, the ventilator is increasing the inspiratory flow. So if it increases the flow, the tidal volume achieved is faster. Understood? See, if you increase the peak flows on a patient or increase the rise time it is like this. On a volume modes, you have to increase the peak flows to deliver the tidal volume shorter in a shorter time, because this is what happens. You are increasing the flow. In pressure modes, it is same, again peak flows, but somebody has called it as rise time. So don't confuse. The ventilator again increases the flow. Though it is called rise time, it is again increasing the flow. So how can you shorten the inspiratory time in a COPD patient in a pressure support mode? Your understanding should be by increasing the flow, one, or by increasing the time. But we don't want to do this. We want to do this in a ARDS patient. But here we want to deliver the tidal volume in a shorter duration and also cut the inspiratory time. To cutting the inspiratory time, what we do is, see, at 100%, when it comes to 25%, it changes. If I shift the inspiration to here, see, if I cut the inspiration to here, I have told the ventilator, when the peak flow comes to 50, you shorten. And once I shorten this, I have increased the peak flows or the rise time so that the tidal volume delivered is same. So this is how you do it in a COPD patient. See, there are only two things. Remember, rise time is nothing but increasing the peak flows. If you increase the peak flows, your bucket fills up faster. So you can have a shorter inspiratory time. So once you shorten the inspiratory time, you decrease this so that you give this much time for expiration. This is how you work in a COPD patient, not by increasing the tidal volume. If you increase the tidal volume, your carbon dioxide will increase. Whereas in an anesthesia situation, it is very easy. IE ratio can be increased. But in a pressure support, when patient is breathing on his own, this is how you manipulate the IE ratio. Just skip these two slides. And another common misconception is CPAP. What is CPAP? What is CPAP? What is pressure support ventilation? See, when spontaneously breathing patient in a heart failure or a sleep apnea, there is only some obstruction to breathing or breathing out or producing some PEEP. In a spontaneously breathing patient, we call it as CPAP. But we don't have much application. The only application I would think is while induction, if somebody you don't have a ventilator, you can tighten your PEEP valve so that the air stays back and if FRC increases. Otherwise, PEEP in a pressure support ventilation, we call it as PS PEEP mode, pressure support PEEP mode. When you just plainly use PEEP in a spontaneously breathing patient, we call it as CPAP. So breathing sequence, only 2 slides. This is a very popular mode with all the juniors. I don't know why. They all think that if you give a mandatory breath once in a while, the work of breathing comes down and patient becomes more comfortable. That is one assumption. And second assumption is if the patient suddenly doesn't breathe, there is some mandatory breaths going on. This is a common misconception all the postgraduates have. And I've seen most of the patients in most of the ICUs, patients will be on SIMV. These are the two presumptions, isn't it? Both are wrong. I will show you that SIMV is a very, very unphysiological mode. SIMV should not be used to any patient. Why? Because what you have to understand is a backup ventilation is there for all ventilatory modes. In a pressure support also, if you say that if my patient has a apnea of 20 seconds, go back to pressure control or volume control. There is a backup. No patient is going to arrest because of lack of breathing. If you set your ventilator properly and tell the ventilator, if a apnea of 20 seconds is there, you go back to this mode as a backup mode, it goes back. So this is, a backup rate is then squashed. There is no benefit in putting SIMV. Then comes the question of respiratory rest. Let us see how respiratory rest occurs. See here. I have a pressure cycled breath and a pressure support breath. See, this is a time cycle. It is touching the time, and here the flow at 25% is changing over to expiration. See, here the patient is breathing on his own with a I ratio, and diaphragm is contracting here, one more breath, and suddenly here, why do you think the diaphragm will stop contracting? How does the ventilator know? How does your brain know that I'm getting a mandatory breath, let me rest now? It is not going to rest. It is going to contract. It is going to contract to generate this breath. On this, you are going to impose a breath like this with a fixed I time and E time. Here there is no fixation of I time and E time. The ventilator manages the I time and E time. Though you may initiate the trigger, sync the trigger, the I time and E time is controlled by the ventilator. Why will the diaphragm going to contract exactly till the I time and relax during the E time? It doesn't happen that way. You see this slide now? See, this is all pressure support breath. There is a mandatory breath here. See, the diaphragm is still contracting. See, there is no rest. In fact, studies have shown that there is an injury to the diaphragm at this stage because the I time and E time are fixed. See, here it is breathing the way it wants. Suddenly, every fourth or fifth breath, if you put a mandatory breath, the ventilator is not going to stop contracting. It is going to contract, and it is not going to contract in synchrony with the mandatory breath. So SIMV is a very asynchronous way of you ventilating patients. You don't require to ventilate anybody with SIMV. See here ventilator is 2 seconds, 4 seconds, but you are breathing at 1 second, 2 seconds. Suddenly, why your brain will adapt to 2 to 4 seconds? It doesn't adapt. Look at the contractions. See, it was breathing like this. See, if I shift this here, it was breathing like this. Now it has to breathe like this. Why will the diaphragm keep quite there? Because you always don't consider the neural or the brain component. See here, the pressure has gone up much more than this. It sometimes may go up. There is something called as a eccentric injury to the diaphragm in SIMV. So SIMV mode is a very unphysiological mode, and 2 studies also showed that if you keep patients on SIMV, the weaning is delayed compared to TPs and pressure support ventilation. See, something to ponder about. So your pressure support does the job, and if the patient doesn't breathe for 20 seconds or whatever you said, it goes back into pressure control. There is something called auto mode. There is something called adaptive support. The modes can be changed. It happens on its own. There are so much technology. There is no need to see. There is asynchrony and diaphragmatic injury. I am sure that a lot of postgraduates will not be convinced. See, I have imposed this breath here. Look at the I time, ear time, and the mandatory breath, I time, ear time. It doesn't sink. Take my word, it doesn't sink, and the diaphragm doesn't keep quiet. It will contract here also. There is no rest. In fact, it gets confused, it gets injured. It goes into dysynchrony, asynchrony. See, diaphragm is still contracting. Diaphragm doesn't keep quiet. How does it? Diaphragm know. Okay, next breath is the mandatory. Let me keep quiet. Ventilator will support me. It doesn't know. You have not proved it. And it doesn't. See, it is like saying that one runner is allowed to run the way he wants. The next runner, you say every fourth step has to be in a certain manner, and you run a marathon. Who will win? A person who is running freelance, the way he wants will win. A person whom you have put, your straight length has to be only 2 feet. Every fourth step, your straight length has to be 4 steps. How can you run? You tell me. It is as simple as that. You can't breathe like that. So it is important to understand no mode is inertly safer. This I have already put it. It is always the framework which we have to look at. Settings are all not different. I have not gone into this. See, again, the same settings are applied to whatever mode you work. Settings don't change. We know what is the tidal volume, and tidal volume is always to the predicted body weight. FiO2 we know, PEEP we know, we personalize. Then we know when to do a recruitment maneuver. Normally, IE ratio is 1:2. There is no recommendation. Respiratory rate is 12 to 18, and always in the framework of looking the lung protective ventilation of a plateau pressure and a driving pressure. So this is something we have already looked into. Then in obese patients, probably the starting peak should be around 7 to 12. There is a guideline to this effect, and this is the lung protective guideline. Settings is same, whatever mode you are in. If it is a pressure mode, only the pressure is for volume. In volume mode, direct tidal volume. The rest all settings are same. Don't think that it is different. So there is nothing to learn there. And this is something you should know when you want to manage alter your SpO2. It is always FiO2, tidal volume, PEEP, I time. Whereas in carbon dioxide, in a normal patient, it will be minute ventilation, but not in a COPD. When it becomes COPD, it becomes alveolar ventilation, because dead space come into the equation. When I speak of COPD, I'll teach you. And the time for expiration. This time for expiration is IE ratio when you are ventilating in the OT. You can always reduce the tidal volume, increase the IE ratio to 1:3, 1:4. You can increase the expiratory time as long as your plateau pressure is less than 15, 20, 25. That you can remember. In a COPD patient, I time can be 1:5 as long as your plateau pressure is less than 24, 25. So that is how you set. But in a pressure support ventilation, in a ICU, there is no IE ratio. You can't set it. There you change the flow, peak flows, or the rise time and expiratory sensitivity. Those are the two things you have to remember. See, rise time and expiratory trigger sensitivity. Thank you.
Thank you, sir.
Any questions? I'll take.
Okay, sir. Thank you. Thank you very much for your excellent presentation, sir. The highlight is you break the myth of SME is the best for the patient for the postgraduates. Very, very nice, sir. So there are few questions I will take it to you, sir.
Yes,
First question, flow trigger or pressure trigger, which is best?
Sir, as I've said, there is the work of breathing to initiate a breath. If it is properly set between 1 to 2, there is no difference. Initially, there are some publications that flow is better because there is already some flow occurring. So patient will feel better. That was the sense. It is like a small pressure support being given at the start of a breath. But later studies and with the increased good technology, nanotechnology, the later studies show that the work of breathing to initiate a breath in both the triggers are same. So, but ventilators with flow trigger are expensive. If somebody comes and says, don't get biased by what he says, you can always buy a pressure trigger with a lesser cost if you are in a rural setup.
Thank you, sir. The second question is, in ASV and SAMV, what is the difference? Is it ASV is better for weaning?
In SAMV, what you set goes. In adaptive support ventilation, it has an equation where it calculates what is the rate and tidal volume, and it makes a rectangle, or it makes a kind of a area on the graph where the amount of space it has, where it can alter the tidal volume and the rate so that the work of breathing is minimum. It has an algorithm built like that. So the tidal volume and the respiratory rate alters in such a way that it is always in that square. For example, in a COPD patient, the area will be more on volume alteration and less on rate. It goes in a rate with very, very small range, whereas volume changes will be more. Whereas when you go to ARDS, the area becomes, rate is more altered and the volume is maintained less. But you can't compare SMV and adaptive support ventilation. If somebody is interested, just send me a hi in WhatsApp. I'll send you the slides of ASV. You can understand. Or else, if time permits, next time I'll just add up 1 or 2 slides and explain what is the difference. But you can't compare the two. That works on a minimum work of breathing principle. It works on a minimal work of breathing principle. This doesn't work. This works on a myth that if you put mandatory breaths, patient will be rested, which you won't. You'll be fighting the ventilator at that time.
Okay, sir. The last question is, the expirator trigger is activated. Already the pressure support is stopped by a deceleration flow. Can you explain what happens next?
The expiratory trigger is a point when the peak flow comes and reaches 25% of the peak flow. For example, let us assume that the peak flow is 100 liters at the peak of his inspiration. It starts deep because at that pressure, at that flow, pressure is achieved. We have set a pressure of 7 centimeters or 10 centimeters. Pressure is achieved. Now we can't give more flow. Ventilator doesn't give flow. It starts decreasing the flow. So when the flow starts decelerating to 25, the delivery of the flow, which was at 100 liters, starts decelerating at 25. The ventilator closes the inspiratory valve and opens the expiratory valve. And the expiration will begin. The trigger of expiration and the trigger of inspiration, don't confuse. It's a expiratory trigger sensitivity. The trigger opens at the end of the inspiration, not at the beginning of the inspiration. I hope I'm clear.
Yes, sir.
Yeah.
I hope Sarva Vinodini madam, you understood that. Thank you very much, sir, for an excellent presentation. There are many appreciation coming on the YouTube and many questions also coming on the YouTube. I will collect them and send you personally, sir.
Okay.
Thank you so much.
Thank you, sir.
We will meet the next month, the 3rd.
Okay, sir.
Thank you. Thank you very much, sir.
Okay, sir.
With that, we will come to the end of this session. I thank the Akrula and A1 Logistics and also the Anaesthesia TV for airing this program. Thank you. Thank you, one and all. We will meet next week. Thank you.
Thank you.